and welcome here back on the EAO channel live, where we are in Lisbon for the EAO Congress 2019, and we're about to start a broadcast of a session live in the auditorium titled How to Treat Cases with Buccal Bone Loss After Extraction. And what this session is going to look like for the next half hour during the coffee break here on site in Lisbon. Welcome to the on-site audience as well. We will look forward to that session, kind of get you ready to make the most of that session. And I will do that together with my expert co-host, Ferruccio Torsello from Rome in Italy. Ferruccio, good morning.
Good morning, Eric.
You run a specialist private practice in orthodontics and implant dentistry, and you're a frequently seen lecturer in many international congresses. So I'm glad you're by my side this morning.
My pleasure.
Since we are live on the EAO channel, you can participate. During the entire session, you can use the chat functionality to send in your questions straight here into the studio, both to me and Ferruccio while we're previewing the session, during the session on stage, because after the session is closed in the auditorium, the speakers will be rushed downstairs here in our little studio, and you will have an exclusive Q&A with our speakers. And that invitation is also to our on-site audience. The speakers come here, you can ask your questions whenever you want. Ferruccio, the topic of buccal bone loss, very interesting, very important. Let's start all the way at the basics.
Yes.
Why is the buccal bone so important when we talk about implant dentistry?
Well, buccal bone is the external part of the alveolar crest, so it is very important because it gives you the support for the soft tissues. So it is important around teeth because it prevents recession. Soft tissues, we know, are supported by the bone, and in the mid-facial aspect, so buccally, they are supported by this bone. So it is very important. And in soft tissues, it may happen that it can be very thin. Sometimes it's very thin. It is also important on implants. On implants, it is even more important because when you have a recession on implants, you have quite often a dramatic aesthetic failure. So we need buccal bone also around implants, and the need is the same because we want to support soft tissues. Also, we want to prevent any peri-implant pathology because implant should be surrounded by bone on 360 degrees for the entire implant length.
Yeah, that's what everybody always learns in dental school, right? What does the textbook say?
The textbook says that we need 2 millimeters of buccal bone on implants.
Exactly.
Okay, so on implants we need thickness which is much higher than on teeth. So it seems to me, or we're always taught that this is a very important feature. Now, absolutely, this is.
Today we talk about buccal bone loss.
Yeah.
What could be causes that the buccal bone is gone?
Yeah, well, buccal bone loss comes for different causes. So it may come from periodontitis, which get the bone resorbed, as you can easily imagine, or also for endodontic failures, for example, when you have abscesses or chronic pathologies which destroy the bone very quickly, or even by fracture. If you have a trauma and you have a bone fracture or a tooth fracture or both, you can lose the bone. But you lose the bone also when you do an extraction. So the extraction per se, it causes bone loss.
The procedure itself,
yes.
Makes it crumbles, it cracks, you lose bone.
Because there is also a reason why it happens, which is, the reason is that buccal bone plate gets some of its vascularization from the periodontal ligament.
Okay.
So when you take the tooth out, you will gonna lose this vascularization because the periodontal ligament goes away, and then you have this buccal bone resorption, especially when it is very thin.
Exactly, because then it easily comes with the extraction. Now, in an average practice, for example, in your own practice, how many cases, as a rough percentage, how often do you come across cases where the buccal bone is gone?
Well, very often, I tell you, because as I told you, it can have a severe buccal bone loss when there are some pathologies, but as the extraction per se causes buccal bone loss, I have very often. I would say that if you have a very thick periodontal phenotype, a very thick bone, then you will not get so much loss.
Yeah.
But there are studies, and also my experience is consistent with these studies, where I would say 15 to 20% maximum are the cases where buccal bone loss is not lost.
Is not. So basically, in the majority of cases.
I'm referring to the aesthetic area, which is the most important.
Where it's most important, because that's where the aesthetic failure, the exposure of implants is the worst.
And when you come to the aesthetic area, it is very, the bone is usually very thin, so after the extraction you're going to lose it.
Well, let me address our viewers who have just joined us. If you're just joining us from anywhere in the world, we are live from the EAO Congress in Lisbon, and we'd love to hear and see where you are from. So please use the opportunity to use the live chat and send us a hello, a greeting, and let us know where you're watching from. And if anywhere during the course of the next 2.5 hours you have a question, please type it in there as well. It will come straight into the studio, and I will relay your message to our guests in the studio, the speakers after the session, or to Ferruccio Torsello. Ferruccio, we've learned many of our patients have buccal bone loss.
Yeah.
What does it mean for my treatment plan? What is the impact when I move forward?
Well, it depends on the area of the mouth. Some area in the posterior areas, you might even live with it.
Okay.
So you can even place the implant. You might have as a slight compromise for the emergence profile of the prosthesis, but you can place the implant and get integration and get the implant surrounded by bone 360 degrees anyway in the posterior area.
Yeah.
But when it comes to the frontal area, the bone loss is more important, and even you could place the implant many times, gaining a primary stability, so this implant will get integrated, but you are not looking just for integration of the implants, you are looking for a nice aesthetic result, and then you have to compensate this bone resorption.
Yes.
So if you get the bone resorbed, you need to rebuild it a little bit, and you can do it in several ways, and then we will discuss about
this. We'll discuss that in a minute, but basically the meaning is I have to do something first. I have to prepare the field, so to say, before I can place the implant and move on to the next one.
Yes, this is also another option, because you can either try to prevent the bone loss by doing something at the moment of extraction, which is the so-called alveolar ridge preservation. So try to maintain as much bone volume as possible, and then go to the implant. Either you leave the socket heal unassistedly, and then when you go at the implant moment, you have to somehow compensate the bone loss and then regenerate a little bit.
Okay. And for our younger, unexperienced viewers, I would say, can you quickly take us along? What are my timing options? What are the options in implant dentistry in terms of timing?
Yes. I think you refer to timing of implant placement.
Yes.
Okay. Timing of implant placement after tooth extraction. There has been a lot of studies about that. You can imagine it's really the daily work of the dentists.
Yes.
So EAO and all these big societies, they got a lot of effort to find classifications and to give indications about this. I would say that let's talk about 4 types. Type 1 implant placement is when you take out the tooth and place the implant immediately.
Okay.
Right.
The so-called immediate placement.
Immediate placement, yes. Immediate placement means that you need to reach primary stability, because this is the first condition to be able to perform an immediate implant.
Yeah.
The implant has to be stable, otherwise. Yeah. And then the other things you have to look at are how thick is the bone wall, which is the distance between the implant and the bone wall, and in case you need to fill the gap into the alveolus. Also, you have to look at the deep depth of implant position. Sometimes you have to forecast a slight resorption of the bone and so and you have to place the implant slightly more deep, slightly deeper. It's not an easy procedure.
Exactly. A lot of things to consider.
A lot of things to consider. It's not straightforward. It's advanced. I would say I would not start as a young clinician. If there is any young clinician watching us, I would not start with this kind of implant placement.
Exactly. Especially not in a case of buccal bone loss, right? Where
Absolutely.
we are fairly already determined.
Much worse.
Yes.
Much worse.
Yes.
I would say yes.
Next option.
Next option is to wait 6-8 weeks. It is called type 2, early placement. You wait 6-8 weeks. You get some bone resorption, of course, but you get complete closure of the soft tissue. So when you get to reopen, to go into implant surgery, you will have very thick soft tissues, very thick, which because at 8 weeks is the moment when the soft tissues are most thick.
At their best.
The best. So it's perfect for the surgeon to work this moment. You can manage the tissues. Also, they can compensate small errors. So it's a friendly procedure, in my opinion. Although the bone is not healed.
Exactly.
So still you have to find a good primary stability. And of course, you will not have the implant fully covered by bone. So many times you have to graft. I would say 90% of cases you have to graft with
Meaning
the
you do an augmentation with bone around the implant.
Bone, the most widely used technique, the most documented one, the most solid one, it consists in placing some bone, autogenous bone. You collect it in the distant areas on top of the implant, then you graft a little bit with a xenograft or with a bone substitute, and you cover with a membrane. There are different type of bone materials and membranes, but usually the procedure is this. Okay. The procedure is advantageous because you have the soft tissues, but still is an advanced procedure because you have to grab primary stability and also you have to augment.
Yes. So what is the third option?
Third option is to let it heal, to let this socket heal for a longer period.
Completely.
Then here we have two sub-options, because when you do like this, when you behave like this, you will probably lose some bone width because you have this buccal bone resorption. But when you go into surgery, you usually find complete bone healing. So you can place the implant, and if you have left the socket to heal unassistedly, you will probably graft anyway, because the bone has got resorbed. In this case, when you wait 3-4 months, the use of something to prevent the socket collapse would be much more...
you mean at the moment of extraction?
Yes.
Exactly. So at the moment of extraction, you would insert something to make sure you can find it.
Yes, you can do both ways, but then you go, if you want to try to prevent bone grafting at implant placement, you have to place something. You could place something into the alveolus.
All right. And how long do we wait for the healing?
I would say 3 to 4 months for this.
And you said there were 4 options?
Yes,
so
the fourth option is when you forecast to place the implant more than 4 months after tooth extraction. Well, it's not really frequent. If you have a tooth to be extracted, you usually plan to replace it before the extraction. If you come to my office and you have a tooth that has to be removed, we sit together, I visit you, and then we already plan the extraction and a way to replace it. Exactly. And usually you will not be keen to wait so
half
much.
A year or what?
Just to half a year just to place the implant.
Exactly.
That's too much.
And then the loading as well later on. So it might take a very long time. Because you very clearly explained the difference in timing and what it means for a clinician or a surgeon.
Yes.
But I think he or she is not the only one making the choice. So what else is
Let's
at
see
stake
from
here?
the patient perspective.
Exactly.
Okay, but the patient is very happy with immediate restorations, the immediate implants. that's obvious. You take out the tooth and you place the implant immediately. It shortens treatment time. In some cases, you can even load it immediately. So think to your central incisor. You will be very happy if we can do all these procedures in one day, in one single session. Of course, as a clinician, I'm not only interested in the speed of the treatment. I'm also interested in the quality and the final outcome, because sometimes it's also worth to wait 2 months, but to have a lifelong result, lifelong outstanding result.
Exactly.
So we have
so this is a short-term versus long-term discussion that you have to have with your patient.
Yes, this is an important discussion. You have to stay with the patient, to spend time with him, and to find, I would say, an agreement, the best possible compromises. Because there are patients who say, I want the best possible result. It may take a while,
as
no
long
problem.
as it takes. Yeah.
But there are also patients which they do not want to stay without a tooth, and they do not want to wear a provisional, to have the problems in wearing the provisional, because provisionals are not always comfortable. Sometimes they are uncomfortable and they may break, they may be removable, so it can be a problem.
And for clinicians watching, having to have this difficult discussion, and then patients who are with Dr. Google in their pocket who say, well, I see all these people who do this in one day. Is there any scientific basis to tell them that immediate is more risky or not? Or is it just reasoning?
All the approaches I've mentioned, they all have some scientific basis. Probably the one which has more solid literature, more solid evidence on this is the type 2, which has been extensively documented. Yeah. It's I would say a Swiss approach, and it is probably the one which has long-term data.
Exactly.
Okay, so it is. Also, I would think about the type 4. I told you.
Type 4 meaning, for viewers who are just tuning in, waiting very long before you place implant and load them even later.
Well, type 4, I told you it is very seldom used. But it may happen that I perform a type 4 procedure when a patient comes to me and he has his tooth missing for years. So it is also present in the offices. So when you take out the tooth, you usually do not go for type 4, but you might go for a type 4 when the patient comes out.
He's already used to the fact that there's no tooth, so you have
to regenerate.
Yeah.
And also type 4 could be used in the unlucky case that a very young patient lose a tooth. So if he's young, could be 15 or 16, and you have to take the tooth out, you will not place the implant in the next years.
Yeah, because they're still growing, the bones are growing, the face is growing, a lot of change going on. The mandible is growing,
the maxilla. There are a lot of studies which suggest us to postpone implant placement. So type 4 could be used in these people, and in that case, it is very important to do something to prevent bone collapse, to prevent the atrophy.
Well, if you are joining us here live on the EO channel, this topic was actually extensively addressed yesterday in our live broadcast, which was all about should we avoid implants in the aesthetic zone, and specifically the topic of facial growth and bone growth was addressed by Marcus Hursler, so I invite you to check out that video as well. If you've just joined us, we are live here at the EO Congress in Lisbon, and we're looking forward to the session, How to Treat Cases with Buccal Bone Loss After Extraction. And that session will start at 11 o'clock after the coffee break, which is in about 10 minutes. It will be chaired by Alberto Sicilia, who you might know as the past president of EEO till last year, and Ronald Jung, who you might come across as the chair of the EEO Congress in Vienna last year. They chaired a session with 3 speakers. First up, we have José Carlos Rosa from Brazil, who will talk about the IDR, the Immediate Dental Volume Restoration Solution. Second, we have Marc Quirynen from Leuven in Belgium. He'll talk about the LPRF solution. And the third speaker, Zabalegui, he's from Spain. and he'll talk about the soft tissue solution. Now, Ferruccio, let's preview a little bit these three different approaches that they will present. What do you know about them? Let's start with the IDR solution, the immediate dental foliar restoration.
Yes, immediate dental restoration is an immediate approach, immediate placement approach, meaning type 1 implant placement. I've never heard this lecturer. I never saw at his lecture, but I've studied his technique. He published several papers on that. It mainly deals with placing the implant immediately after tooth extraction and grafting it. But grafting in a peculiar way, I would say, because his technique it consists in taking a three-layer graft from the maxillary tuber.
Okay.
Where there is usually bone and where there is a very thick and dense connective tissue.
Yeah.
So he has a technique that we will see together during the presentation. He harvests this graft, a single piece with 3 layers: connective tissue graft, cortical bone, and spongious bone, cancellous bone. So he then shaped this graft and place it between the implant and the soft tissues. So he creates a pouch where he inserted this graft. And I know this by the literature, but I'm very interested in this approach because it looks a little bit, how can I say, aggressive.
It's doing all things at one time.
Yeah,
extraction,
everything is done in one
implanting.
single procedure. And this guy comes from Brazil. He's a very good lecturer, very good clinician, and they might have this, how can I say, tendency to immediacy. And
listening as a potential patient sounds great.
Of course it is.
Tell me, as a scientist, as a clinician, what is the risk here?
Well, the risk is that this grafting procedure doesn't work properly, or doesn't work, and then you have to, you will end up with suboptimal result, and so then you have to deal with this, or to either the patient accept it, either you have to fix it. And you know, it's an approach which is very fast. I want to hear from the lecturer which are the pros and cons. To me, it sounds really, really, really interesting.
Yeah,
okay,
it's interesting if it's easy to do, but you're taking a lot of risk in the sense that you're doing a lot of things at the same time.
Yes.
And if anything goes wrong along the way, your whole project
I don't think this is an easy technique. I don't think this technique could be recommended for people who are getting into implantology. But when you are experienced, you are also open to new procedures, yes, to go to the next step. So I think it will be very interesting. A lot of debate, I forecast a lot of debate about this.
Well, and let me invite our viewers as well, both here on site and online. If you want to participate in that debate after the session, make sure you make use of the opportunity to submit your questions or arguments via the live chat, because I will relay them to Ferruccio and to the speakers right here in the studio. Now, next up we have Marc Quirynen. He talks about the LPRF solution, which is the abbreviation for the leukocyte and platelet-rich fibrin.
Yes, it is a blood derivative. These membranes, because these come after blood centrifugation, these membranes came out. They are rich in fibrin, rich in leukocytes, rich in growth factors. And Marc Quirynen has an extensive experience about that, sound scientific background. So he usually places these membranes into the socket immediately after extraction and waits healing.
Okay.
You are placing into the socket something which is not which is a biomaterial, but it's 100% natural. It comes from patient blood.
Yeah.
Meaning that
it's your own body.
You place your own growth factors into the socket and you let it heal. So it will take some time to heal, but it's very natural, and there is some evidence that this prevents bone atrophy. So later on, yes.
Yes,
so
exactly.
The idea is to place this inside and then into the graft, into the socket, and then wait And the idea is that when you go for implant placement, you should not graft at that moment.
Exactly.
So this is
So
successful.
it sounds like quite a. I was going to say conservative, but that's not it. But in timing-wise, it's a long-term project, and first you fully restore
Yes.
the arch and the environment where you place the implant, nature-based, before you go in with it.
Yes, and then when you place the implant, you are supposed to place the implant in an easy procedure. No grafts,
Exactly.
and maybe some soft tissue grafts, but not bony graft usually.
Interesting. And I've learned from Marc that he will present two different cases, one with a single tooth and one with a situation where there's a lot of teeth lost and what that means.
Yeah.
The third speaker, Zabalegui, he's from Spain. He will be sharing the soft tissue solution, and this is basically, as I understand, a technique that he has kind of invented. He's been using in his own clinic. What do you know about this story?
Well, I know, but the story is basically is that he placed the implant immediately after tooth extraction, and it doesn't graft the space between the alveolus and the implant, and he just places he uses soft tissue sealing. So he places soft tissues on the implants. He has a lot of cases treated like this, but the spicy issue is when you have exposed implant surface, because that is the issue. And well, Jon has around 50 cases when he has exposed exposed implant, so bony dehiscencies, and he does not augment the bone, he just augments the soft tissues.
And basically, he goes against what we started off this preview with, the old textbook, which states you need at least 2 millimeters of buccal bone.
Yes, yes. This is something that has to be carefully evaluated, because basically you are perfectly right. I've been told at the university, in my postgraduate programs, at the private courses everywhere, that I need 2 millimeters of bone. And now Jon comes up with this technique, which works pretty well in his hands. And he thinks and he demonstrates that this is not so important to have the 2 millimeters of bone, but just go slow, because we have just to slow down a little bit, because we have to ask him if it is a technique that works in his hands, or if it is a technique that can work
for everyone.
Widely.
But the exciting bit is we could be looking at a true innovator in the field of implant dentistry. It could be that later in history we look back at the EO Congress 2019, where Jon has presented
Yes, but of course we need publications. We need publication, peer-reviewed journal, when you send the data and you and someone else review the data. So
we'll have to wait for that. But let's first learn what he does. Ferruccio, thank you very much for guiding us into the session. Thank you for joining us here in the coffee break. We're about to take you upstairs into the auditorium, and let me remind you once again, the 3 speakers that you see on stage will come down to the studio right after the session, and they will take your question. It's exclusive content here on the EO channel, so if you have a question from the people on stage, use the live chat to send that in. Let me look behind you. The room is full, the session is getting ready. I hand over to Alberto, Sicilia, and Ronald Jung.
Good morning, ladies and gentlemen. On behalf of Alberto, Sicilia, and myself, we would like to welcome you to this session today. And I can tell you we are both very excited. And it's not just 3 speakers which are very excited. We had yesterday a briefing session, and also within the briefing session, it was so heated up about a topic which we think is going to be a very hot topic, a topic which is going to bring different perspective in implant dentistry, and a topic about how to treat cases with a missing buccal bone And we will see 3 really innovative aspects about how it's going to be handled. And I'm going to guarantee you, we will have a lot of fun and we'll have a lot of controversial discussion. In this sense, I'm very much looking forward to. I would like to hand over to Alberto, which gives us a little bit an introduction to get into the topic. Alberto.
Thank you, Ron. This is my task today, to give a brief introduction to this controversial topic. Flapless immediate implants was a controversial topic. I don't think it is any longer, because now it's widely used in all the areas of the mouth. And many implant companies have even developed different implant size and shapes to be adapted to this kind of technique. So now what we were planning is to go one step further. We were planning to treat this kind of incomplete alveolus with the loss of the buccal plate, partial or total loss of the buccal plate. How did we handle this in the past? In the late 90s, we did things with a flap approach. We extracted the teeth, we graft the defect, and we protect the graft by means of a membrane or a connective tissue graft. Well, what we began to do after 2005 is to try to do it with a flapless approach. Same procedure, but without flap. Without flap, without sutures, and our suture was the provisional prosthesis. So that means flapless implant, immediate implant after extraction, immediate reconstruction, and immediate tooth replacement. My task today is to review the evidence, which is weak, but exists. Please keep in mind that for many academies and institutions, immediate implant in incomplete buccal wall alveoli are forbidden, are contraindicated. I don't believe this is the case, but the evidence is weak. We found out, as you see here, 10 studies with 134 implants, and all of them have in common that they treat class 2 alveolus with buccal loss of the buccal plate and normal soft tissues. All of them use conical implants, different brands, but all the authors use a conical implant for that indication, and all of them do flapless immediate implant placement. In red. In red are the ones that also use a provisional prosthesis, screw retained. And in blue, 3 papers use some other kinds of covering the alveolus, such as a customized abutment, a socket seal surgery, or a provisional prosthesis. The majority use for bone grafting or for bone substitute, DBBM, with or without collagen, and some authors, as Ronald and Rosa, who are the authors of the most relevant papers, use autogenous chips or autogenous blocks from tuberosity. The situation is a little bit heterogeneous. It's a biased investigation with no controls, with authors with high experience. But if you allow me to summarize the results, I can tell you this. The success rate is between 94 and 100%. The per-implant bone levels show to be stable. Pink aesthetic scores were high. There is no significant clinically significant soft tissue recession. And in some of the cases where we have convinced CT post-op in the follow-up, we have a reconstruction of the bone, of the cortical bone. We initiated this way in 2008. This is our first case, an old lady with a fracture. We treat this lady. That was being followed over time for 7 years, because we ended our study in 2014. As you can see here, comparing first year with 7 years, tooth number 11, who is the implant-supported restoration, is more stable than the neighboring teeth. What were our results? We treat between 28 and 2014, 60 cases. 20 splinted and 40 single tooth cases. Severe cases, as you can see here, 40%, 47%, almost 50, were class 2C with complete loss of the buccal plate. And we've got one failure at 5.6 years, which gives us a success rate of 98.3. We also evaluated interproximal bone level stability by means of comparing calibrated digital radiographs. And we found out that between the 8 weeks and 1 year, we have a change of 0.22 millimeters, and between 1 year and 5 years, we have 0.26 millimeters. That means stability in the bone, interpersonal bone load levels. We evaluated the aesthetic scores, the pink aesthetic score, comparing with the contralateral teeth. In the 40 unitary restorations, we will be able to have 37 cases with contralateral teeth. And we found high aesthetic scores. We have this cloud of points, which are all the 37 patients. We classify them according to the classification proposed by COSIN and also used by Aurora. In excellent results, in blue, 79%, good aesthetic results, 16%, and the so-called aesthetic failure, 5%, which receives a 7-point score, which is the top level of the bad classification. That means that 95% of the cases resulted in good or excellent aesthetic results. We also have a patient evaluation, subjective evaluation, with 98% success rate, and almost 80% had no significant soft tissue recession. So this paper is going to be published. It's accepted for publication in Clinical Implant Research in year 2020. And if we add this paper to the previous review papers, we have 11 studies and almost 200 implants, showing good success rates, soft tissue and hard tissue stability, and in some cases, bone reconstruction. Does this mean that we have to do it tomorrow, next morning in the clinic? No. This is a little bit biased. We have evidence. We thought we have not evidence. We have it, but low. And this is biased because it's done by clinicians with high levels of experience in their own technique. So there is work to be done, but I would like to say that this is not a contraindicated technique, can be done. And with that, I would like to call on the stage to our first speakers, Dr. José Carlos Rosa. He's a multidisciplinary, well-trained dentist with education in prosthodontics, periodontics, and with a PhD on implant dentistry. He is the author and the designer of the immediate endothelial restoration, and I strongly believe that we are going to have a very nice time listening to him. Your turn.
Thank you so much. Good morning, everyone. My name is José Carlos Rosa. I came from Brazil. And first of all, I would like to thanks for the opportunity to be here, and thanks for the invitation. This is my first time in EAO, and I'm very happy to be with you today, especially to participate in a very high-level session with my colleagues, Marc, Jung, Alberto, and Ronald. It's a great pleasure to be part of this group. Here you can see two different scenarios, in the dental side and post-extraction area. According to my point of view, we have very different dimensions of these two different situations. A post-extraction socket would never become an edentulous area for late implantation. It's because it would increase the number of the procedure, the cost and the treatment time, and of course, the unpredictability of a result. Talk about the excellence of aesthetics regarding gingival margin and papillary height position. This is why I recommend you that in post-extraction socket, my first preference is to do everything in a single procedure using flapless surgery. And don't forget that the decision-making belongs to the dentist, not to the patient. In this case, in this second premolar, we have a huge defect, and according to my experience, this is the right way to manage this, to apply the IDR technique using bone graft at the time of immediate implant placement and provisionalization in compromised alveolar sockets. And the main goal of this technique is the preservation and the regeneration of the natural biology. This is the immediate dental restoration concept. This is a minimally invasive approach. This is a flapless surgery, but all credits go to the mother nature. We take advantages about bone biology, and we take bone from the tuberose as a bone transplant using chisels, and we use this bone as a biological membrane in order to restore the buccal wall that the patient had lost. Not only the corticocancellous bone, but also particulate bone in order to fill completely those gaps. But what's the importance of using a graft as a natural scaffold filled with osteoblastic cells and growth factors? If the patient lost the wall, why not to give back another wall as a biological membrane? This is why I personally believe that if we use a biological membrane like this, a corticocancellous graft harvest from the maxillary tuberosity, you may have results like this: soft tissue stability, and to get a bulky soft tissue along the months and along the years. You can see here the post-op of this case after 10 years, a very thick buccal wall, and the bone graft that we had placed over the implant platform is still remain and remodel over the implant platform. Here, the IDR literature, the IDR based on evidence. We have already published 22 articles about this topic. 3 more articles were recently accepted for publication. The IDR book that was published in 4 languages. And we have 9 book chapters in different authors around the world. And we did this clinical research. We evaluated the regeneration process of the bone grafted. As you can see here, the first premolar, a hopeless tooth. We extract this tooth, we insert the implant. As you can see here, we did the bone reconstruction, provisionalization. In 3 months, we took the impression and we made the final restoration. And we left, as we usually do, a gap around 3 millimeters at the buccal aspect. As you can see through these 5 sagittal views, after 2 months, you have the early bone graft remodeling. After 4 months, total bone graft incorporation. This is what we are expecting when we use this methodology in my patient's mouth. And after 6 years, you may have there the graft stability. We still have the 3 millimeters of bone grafted. Here, in this article that was published in 2016, we did a clinical research. We evaluate 20 clinical cases. All of them presented total loss of the buccal wall. And we use this methodology, 3 millimeters of gap at the buccal aspect. And we perform the IDR technique. And we evaluate the bone graft dimensions, the most important part of the graft, the cervical portion of the implant. And take a look, 35 months as a mean of follow-up. Up to the implant platform, we got around 3 millimeters, 2 millimeters above letter D. You can see here letter D. We find around 3 in letter E, around 3 millimeters. So we got a very good stability of this bone. This is another clinical research. We evaluate 18 cases. It was published 2 years before. And we evaluate clinically the maintenance of the anatomical contour and gingival margin. And in a follow-up of 58 months as a mean. Here are our outcomes. We evaluate the crown's length, and we have no recession in these 18 cases. And the mesial papillary level and the distal papillary level is slightly increased over time. From now on, I'm going to present for you some of the indications of the IDR technique. Let's start talk about cases that presented leveling of gingival margin. This patient, she is a dentist, and she presented the right central incisor hopeless tooth. We have to remove this tooth. But take a look, we have gingival margin symmetric. It was missing the buccal wall. We extract the tooth. We confirm the absence of the buccal wall. We insert the implant in the palatal wall anchorage. We left a gap around 3 millimeters. We make the provisional restoration using the same crown from the patient. And we left this space and an under contour in the cervical area that we call a gap of soft tissue in order to promote a soft tissue ingrowth over the bone graft. To take bone graft from the tuberosity, we need previously to evaluate clinically, tomographically, and also using CBCT scan. These are the chisels that we use to apply the IDR technique. And the chisel has to be placed as perpendicular as possible to the bone architecture. As soon as you go deeper, we change the angulation of the chisel in order to harvest a graft with the dimensions very similar to to the defect dimensions. Right after we harvest this graft, we reshape the graft according to the defect configuration. Take a look that we also reshape the anatomical contour, the cervical area that should match the outline of gingival margin in order to restore the bone architecture that the patient had lost. And we fully filled these gaps with particulate bone, and we left bone graft 1 millimeter over the implant platform. And we install immediately the provisional restoration, of course, out of occlusion. 3 months later, take a look what happened with soft tissue. We changed the position of the graft, and the soft tissue obeyed orders. The soft tissue has been moved coronally. After 3 months, to push the soft tissue in the apical direction, we added composite resin every once a week for 2 or 3 weeks. As soon as we finished this task, we removed the provisional restoration in order to evaluate the soft tissue quality, the maintenance of gingival architecture, the soft tissue volume. We took the impression, we made the final abutment, and the final restoration. And here you can see the post-op after 6 years, the clinical view and the CBCT scan. The new buccal wall completely remodeled and stable. So if you have around 3 millimeters of bone at the buccal aspect, you do not need to compensate with soft tissue graft. That's the way that we've been working the last 13 years. How about case that patient presented gingival recession, like this? In this case, we should use another graft, harvest from the same donor area that we call a triple graft, a graft with 3 layers: connective tissue, cortical, and cancellous bone in one single piece. This is the first article in the international literature published by my team 10 years ago, as you can see here. So what we did here, we have a gingival recession around 4 millimeters, a patient with a high smile line. We extract the tooth. Take a look how thin the soft tissue is. We insert the implant 1 millimeter from gingival margin in the corner direction. We make the provisional restoration, and we left intentionally the same anatomical contour of the provisional restoration that we call a soft tissue gap. We went to the tuberosity, and we harvest from the tuberosity a triple graft, as you can see through this illustration. And we use blade, we use chisels in order to harvest a graft with this shape: connective tissue, cortical, and cancellous bone. That's the way that we manage this graft. The cortical, the connective tissue is turned toward the inner part of soft tissue, and the marrow portion to the other side, to the implant body. But in between, we should insert particulate bone. 1 stitch was enough to hold the graft in the right position, plus 2 more stitches in each papilla. And pay attention that we left here the cervical area, the gingival margin, exactly in the same level of the opposite side. 4 months after that, the biological width was retrieved, and take a look at the improvement of thickness in the implant positioning. We took the impression, we made the final abutment, and we delivered the final restoration. This is the post-op. We have the balance between gingival margin and the papillae position. Just to make a comparison prior, apply the RDR technique and after. And here you can see the balance between the lips, the gingival architecture, and the crowns. And this CBCT scan was taken after 10 years. 10 years later, we still have a very good thickness of bone at the buccal aspect. Next clinical case, we have two questions for you. Which bone graft material would be indicated to treat condemned tooth in combination with infected site and severe bone loss? Severe bone loss means something like this. And how to improve implant primary stability in case with low or no remaining bone in periodontally compromised sites. Let's follow very quickly this clinical case. This is a periodontally compromised site. The periodontal pocket was around 12 millimeters in depth. Here you can see the extension of the bone defect, the roots of the neighboring tooth, the sinus floor, and now this is our scenario. We have no remaining bone to stabilize this implant. How to do it all in one single step, applying flapless surgery. Predictable. So, as we had infection, we prescribe antibiotic therapy. We clean the socket, we remove the granulation tissue, and you can see through this immediate X-ray the big hole that we have to restore, to rebuild. We went to the tuberosity in the same site. We harvest bone, and we split this graft in 3. The particulate bone was packed in order to fill the apical part of the socket, plus 2 pieces of cortical cancellous graft, one at the buccal aspect and another one in the proximal aspect. So we fully fill these gaps with autogenous bone. And here, we are just moving bone from the tuberosity to the receptor site. As you can see, make a comparison of these 2 X-rays before and after bone reconstruction. In the middle, you can see particulate bone graft. But in the distal aspect, a piece of cortical cancellous graft with the cortex turned toward the remaining bone, and the marrow portion to the future implant body in order to reduce the size of the socket and to improve implant primary stability against this wall. So we did this site preparation in a counterclockwise rotation using ossidification concept. And we densify bone through bone compaction. The bone was densified laterally and also apically. We took advantages about bone plastic deformation. But the question is, can we use this approach using biomaterial? Of course not. So the autogenous bone graft for these cases, this very challenging clinical case, is the key in order to succeed. So this is what we are doing when we use this drill. We pack graft in this direction and also in this direction. But we can also go inside the sinus without tearing the sinus membrane using this methodology. At the most 3 millimeters, this is what we did. You are going to follow right now. So we insert the implant. We got primary stability of 35 Newton centimeter. We made our provisional restoration, and we left our provisional crown out of occlusion. And take a look also the correct three-dimensional position of this implant in order to succeed with any kind of the technique. And this is the CBCT scan that was taken right after we did the surgery. And take a look, the amount of bone that was packed was condensed above the apex of the implant. 3 months later, we took the impression and we made the final restoration. And pay attention to the quality of soft tissue around this implant. A very thick soft tissue. This is the X-ray. 4 years, make a comparison how everything started. You can see a huge difference. We can see bone all around this implant, completely remodeled. And we can see also the new crystal bone between these 2 implants. And everything was solved in one single shot. This is the clinical and tomographic post-op after 4 years. Make a comparison before and after. You can see bone at the buccal, the palatal aspect, and the bone graft that we had placed over the implant platform is still remain and remodel over the implant platform. And you can see at the apex, the bone completely remodeled over the apex of this implant. This article was recently published by the International Journal of Periodontal and Restorative Dentistry, the use of the immediate dental restoration combined with ossidification periodontally compromised sites. This is the last clinical case that I'm going to share with you. In this case, the patient lost the papilla between 2 central incisors, and these 2 central incisors are condemned to be extracted. Of course, this patient lost completely the papilla between these 2 central incisors. The papilla was partially lost between central and the lateral incisor. And we have a huge difference between the current gingival architecture and the original one. So I wonder, if we extract this teeth, how would we solve this big trouble after that? So, which is the treatment of choice in order to succeed? If you go what the literature has recommended to us for many years, we can do the teeth extraction to apply guided bone regeneration, implant installation, soft tissue graft, maybe 2, 3, maybe more, and implants uncovering. In total, maybe 5 or 6 surgery. If we go through this way, we would expect some unpredictability of results. Talk about the real gingival margin position and the papillary height position. We went in a different direction. We applied orthodontic treatment, slow orthodontic treatment. The orthodontic treatment lasts 1.5 years. And we still have the crestal bone deficiency between these 2 teeth. Despite we have a good amount of available bone in both tuberosities, as you can see in both sides, both central incisors presented total loss of the buccal wall. What we did, we confirmed the absence of the buccal wall. We struck these two teeth as traumatically as we could. We did the site preparation, and number 11, 21, and implant installation. This was the guide that we used to insert the implant. We make the provisional bridge immediately with ideal emergence profile, and we did the bone reconstruction at the same time, using cortical cancellous block harvested from the maxillary tuberosity. Here we are adapting the bone inside the host, and we crush the remaining bone in order to fully fill those gaps. This is what we are doing here. And we also restore the crestal bone in between these two implants. This is why we are doing here an incision underneath the papilla using a microblade very carefully, very gentle. We remove the granulation tissue and we pack bone underneath the papilla, just small particles. These are the reconstruction that we did at the buccal aspect, and also at the crestal bone. As soon as we finish this task, we insert the provisional bridge immediately. So 3 months post-op, make a comparison before and after. We have the maintenance of the anatomical contour of soft tissue. After 6 months, if we make a comparison how everything started, we have huge difference in gingival architecture position in the apical coronal direction. So after 4 months, we took the impression, but take a look. Let's evaluate the periodontal biotype. In these two central incisors, we have a thick periodontal biotype around this implant. But in the neighboring teeth, lateral, and canine, we have a very thin periodontal biotype. So we took the impression, we made the final abutments, and I want to call your attention that in 4 months, we have the crestal bone completely remodeled, as you can see here, between the implants. So after we cemented the final restoration, this is the post-op after 5 years, the maintenance of the anatomical contour of soft tissue here. And this is the patient after 5 years. You can see through this occlusal views the maintenance of the volume of soft tissue. And we published this case in 2018 by Quirynen I, Quintessence of Dental Technology. And take the home message. Don't remove the bone. Just move it as a bone transplant from the donor side to the receptor side in order to get a result like this. We have a global training, a 3-day IDR hands-on course all around the world. So this technique has a high predictability, is very simple to be reproducible, and represents low cost for the patient. And I think it fits very well what Dr. Marc used it to say for all of us, that less is more. Thank you very much for your kind attention.
Don't run away, José.
I'll stay here.
Thank you very much for your very stimulating lecture. I wrote down a bunch of questions. I'm going to guarantee you we have a great discussion. I can hear already people are discussing. I think that is the right way now to introduce Marc Quirynen. Please come on stage. Marc Quirynen is professor and the head of the perio department in Leuven, a very famous department.
Thank you.
And also Marc stepped into fields which opened new doors. And I know also Marc has now a lot to say to us. He is very passionate about using another autogenous material, a material which we got from blood, the LPRF solution for situations where we have missing buccal bone plates. And I can tell we are very curious and looking forward to what you have to tell us today. Please, welcome, Marc.
Thank you. Dear colleagues and friends, also, I'm very honored to talk to you about the use of LPRF, LPRF standing for leukocyte and platelet-rich fibrin, in the treatment of buccal bone loss after tooth extraction. I think I need one of the remote controls. I could, of course, finish with this presentation and tell you that this is an optimal treatment option, but what I would like to show you in my presentation is the simplicity of this technique. And that is, I believe, one of the big advantages of this story. In the first part, I would like to talk about the use of LPRF membranes, or plugs for rich preservation. And in the second part, I would like to talk about the horizontal bone augmentation using an LPRF bone block. But perhaps for those that are not so familiar with the LPRF, how to prepare it. The preparation is in fact extremely simple. First, we have to draw blood from the patient, like your physician will do when you go for a blood analysis. But in this case, we are going to use special tubes with a glass coating on the inside. And, dear friends, keep in mind, there are no additives in the tubes. So we are not going to change the composition chemically of the blood of the patient. We just perform a mechanical manipulation. Often we take 8 tubes of 9 ml and sometimes even 16 tubes. And this is not really an issue for the patient. In a second step, you have to put these tubes into a centrifuge. Working with the intraspin device, you have to put it at 2,700 rotations per minute, and this for at least 12 minutes. If the patient takes some anticoagulant medication, you have to go to 15 or even 18 minutes. It all smells very simple, but there is one aspect that you have to keep in mind, and that is the time between taking the blood and putting the tubes into the centrifuge. This time cannot be longer than 1 minute, otherwise you will not get nice membranes afterwards. But it takes around 50 seconds to get 2 tubes of blood. So what do you have to do? Once you have your first 2 tubes, you put it already in the centrifuge, you start the centrifugation. In the meantime, you take 3 and 4, and when 4 is nearly filled, you stop the device, you add them into the centrifuge, and you start it over up again. Same for 5 and 6, and the same for 7 and 8. So you have to load your centrifuge 2 by 2. After 12 minutes of centrifugation, you have a beautiful separation in your tubes between red blood cells at the bottom, an acellular plasma at the top, and in the middle, the construct of interest, the LPRF clot, like a kind of an escargot. You can grab that clot with a pincet, as you can see here. Pay attention, the outside is not sterile. You remove immediately the red blood cells, and then you can go to the last step, step number 4, where you will compress these clots into membranes. Normally, you have to use this special kit, but here we have used a glass plate to show you what happens. And as you can see, a lot of liquid is leaking out of these clots. This liquid is called the LPRF exudate. And that exudate, my friends, has an antibacterial capacity and is very rich in growth factors. So if you collect some bone chips, this is a liquid in which you can store it. After 5 minutes of compression, gentle compression, you will obtain finally these kind of membranes. And these membranes, my friends, are very strong. This membrane was blood 20 minutes ago, and now it can carry half a kilogram of instruments before it will rupture. What? So you can suture these membranes, you can pin these membranes. They are really extremely strong. So, just some issues. Time taking blood to having the membranes is around 20 minutes, but you can use these membranes for the next 3 hours. They are not expensive to be produced. Consumables around 8 euros or 10 euros for 8 membranes. As you have seen, the technique is very simple, and And, my friends, this material is 100% autogenous. Is it useful? Well, you can use these membranes, for example, for ridge preservation. After an atraumatic extraction, and after removing all the pocket epithelium, and after cleaning the socket, and also these deep defects for which we often use a ball burr, we will prepare some envelopes, a space in between the flap on one side and on the bone the other side, kind of an envelope. We will rinse the socket with the LPRF exudate, antibacterial capacity, remember? And then we will apply in the socket the LPRF membranes or plugs. Here you see a plug. It's basically a clot that has been compressed into a cylinder. And then, and this step is very important, we will seal the entrance to the socket with these membranes that are pushed into the envelope that we have prepared beforehand. And then we simply suture, not to approach the two flaps or to close the wound, but just to keep the LPRF membranes in position. And if you don't see enough bleeding, it might be wise to make some perforations in the surrounding bone. Is this useful, my friends? Well, here you see a case where we have to remove the first premolar because of a quite deep pocket of 10 millimeters and more. After the extraction, we found out there was no buccal bone plate any longer. And here you see the healing after 1 week. And if you look under higher magnification, you can already see how the connective tissue is growing over these membranes. And also the color is changing because of the formation of new blood vessels. And this is the healing after 3 months. On a cone beam, it looks like this. A cone beam, my friends, after 3 months. This in red was the initial position of the bone. And look what we could augment it. And then we decided to do a re-entry after 3 months. And look what we found. Keep in mind, dear colleagues, on this side here, there was no buccal bone. And we also did not use a bone substitute. This is all natural, well-vascularized bone. So we could immediately go for an implant placement, more than enough space, the X-ray in 2014 and in 2018. And here you see a very short video on this technique. Here we are preparing the important step, being the envelope between bone and flap, to slide in the LPRF membranes to seal the entrance to the socket. And here now we have the plugs that are placed. This is already number 2 and number 3. And then we have to compress these plugs to remove all excess exudate, to have the best composition and the best dense filling. And then finally, the superficial membranes that we will slide in to the envelope around the entrance of the extraction socket. Post-operative care, it's material from the patient, so no antibiotics, no corticosteroids, and keep in mind it also has an antibacterial capacity, so there will be no plaque formation on top of these membranes. Some cases, these cases are from the study from Andy Temmerman from our department. You see the conditions before, and these are the conditions afterwards, after 3 months of healing, where you can see a nice reformation of the buccal bone plate, a slight resorption of around 1 millimeter, but definitely not more. And these are cases from another PhD student of our department, working at the Los Andes University in Chile with Nelson Pinto. Cases before, and the healing afterwards. My chairman, Ronald, asked me to give data, otherwise he told me he would kill me. So I prepared this nice table, which you of course cannot read. But if you like to see it, you can always send me an email. But just to summarize, 6 papers showing that you have a clear reduction in rich resorption with this technique, clear improvement in complications, less pain, less swelling, and so on, also for the extraction of third molars, a much faster soft and hard tissue healing, and also a higher bone quality. But what should we do if we have class 4 bony defects, and this over several teeth, like in this case here, where there is nearly no bone anymore? Then we propose you to work with an LPRF bone block. And also here, the preparation is quite simple. First, you take 2 membranes, and you chop them in small pieces, really small pieces. Why? Because these small pieces of membrane, they contain a high concentration of activated blood platelets, and we need them a little bit later on. Then you take a bone substitute, and you make a homogeneous mixture. Normally, we would suggest you to use 2 membranes for half a gram bone substitute, 4 membranes for a gram, and so on. Volume-wise, it would be 50-50. In a third step, we have to collect liquid fibrinogen. For that, we are going to use another type of tube with a plastic coating on the inside, with an inert surface, and this to delay the coagulation. These tubes you have to spin for 3 minutes. After 3 minutes, you will see a nice separation with a nice yellow liquid on the top, and that is the liquid we need. A liquid that contains a lot of fibrinogen. And now we have another small problem. This liquid fibrinogen can be used for the next 30 minutes only, so you have to speed up your work a little bit. But once you have made these LPRF bone blocks, they can easily be stored for several hours. Here you see how we add the liquid to our mixture. And what do we get? The activated blood platelets will convert the small fibrinogen chains into a beautiful 3D fibrin network. And we get something like a block. It has the mechanical properties of the gummy bears, like, you know, these candies. And, man, you have to steer gently. Otherwise, you will end up with scrambled eggs instead of a nice omelette, with small pieces instead of a nice block. So the condition is take 2 membranes for half a gram bone substitute. And how do we have to proceed? Well, first you prepare a crestal incision and a full thickness flap. You remove all remnants of periosteum and connective tissue. We often use for this a burr. We are going to release the periosteum in order to be able to advance it coronally. We will make a number of perforations in the recipient bone in order to improve the blood supply. And then we will pin a collagen membrane high up on the buccal side. We'll apply the LPRF bone block. Then we will pin the collagen membrane on the palatal side, and then we will cover it with LPRF membranes. What the hell, why would we need these LPRF membranes? Simply, when we have a wound dehiscency, it will help the soft tissues to heal, and the healing will be much faster. Plus, it has antibacterial capacity. No plaque formation. And then you have to suture, preferably for a healing by primary intention. So the flaps together. But if that does not happen, it's not really a big issue. Let's look to one case. This lady wanted to have implants in the upper jaw, but these are the cone beam pictures. Okay, we have 4 millimeters in the second quadrant. You could work with narrow implants, but in the first quadrant, we have 3.6 and 3 millimeters. She went to one of our colleagues, and he suggested to use bone blocks. And the patient could select either from the hip, the skull, would be easy for me, but for a lady, or from intraorally, but she refused this. So we performed this small intervention. Raising a flap, we inserted 2 narrow temporary implants to support the prosthesis, the application of the bone block, collagen membrane, the fixation of the collagen membrane, and then to cover it with the LPRF membranes. Here you see consecutive cross-sectional images from the first quadrant immediately after the intervention. Question to you, my friends. No reinforced membranes. How would you think this would heal? Think about it for a second. In red, the original position of the buccal bone, and this is the healing. In the front, immediately after surgery, and the healing. Second quadrant, after the surgery, and the healing. Isn't this unbelievable? And I can promise you, dear colleagues, the technique is extremely simple. And even here, in the meantime, we have some more cases. We saw some vertical augmentation. And just to show you that I'm not playing and manipulating my pictures, these are the consecutive axial slices, the before and the after. And if you look carefully, you also see a clear densification of your graft that can only be explained by the formation of bone. And this, Ronald, since you were pushing me a little bit in the edge, this is histology. And you see here histology with bone formation over a distance of 10 millimeters. These entire 10 millimeters were the result of an augmentation. And here you see, just in a very short video, the technique, the perforations that are made. And keep in mind, this surgery was done by a second-year postgrad student. Second year. In his first trimester, so he was 1 year and some months with us. To release the periosteum, to be able to close the flap afterwards, the application of a resorbable membrane, the fixation, either with pins or with screws, the nice opening that has been created, here you see now the LPRF bone block. Of course, you can shape it, you can remove pieces of it if it is too big. You see also small parts of membrane. And then the closure of the membrane on the palatal side. Do we have any clinical support for this, Ronald? Well, before coming here, I have put the search term PRF block and dentistry and I was only able to find one paper, and that's one paper from our department from Simone Cortellini, who reported on 9 patients and 14 sites. If you would like to see the details of the study, please look for this paper. I can only present to you the summary. Simone had a cone beam before surgery, immediately after augmentation, and then a third one, a control after 6 to 8 months. And on these cone beams, he did some linear measurements at 2, 6, and 10 millimeters away from the crest to measure how much we could augment, and especially to look for the resorption afterwards. And it was no problem whatsoever to add 4 millimeters to the crest in a horizontal direction. He also did some volumetric measurements to look for changes, and he observed a resorption of around 16%. So if you would like to follow this technique, we would advise you to over-augment 15 to 20%, but not more than this. Fortunately, Ronald, today we have a second study, not yet published, I'm sorry, but on its way, when we have now the results of 30 patients with more than 40 sites, and the first patients are now with a follow-up of more than 3 years, with an overall gain, horizontal gain, bone gain of 4.6 millimeters, a resorption of the graft of around 16%. One graft had to be repeated because it failed in the first surgery, but was successful later on. And all implants, dear colleagues, that have been inserted in these grafts are still in without any complications. And keep in mind, this technique is extremely simple and also very forgiving. Working at the Catholic University of Leuven, I'm of course very happy with this. I'm also very proud, and I have to thank the EAO for the fact that they asked us to organize a workshop on this topic, talking about ridge preservation, sinus floor augmentation, the coating of implants to improve the osseointegration process, the treatment of periimplantitis, the use of LPRF to enlarge the zone of keratinized tissue, and how to work with the LPRF bone block. And this will be done in next year, March 6th and 7th, together with my good friends Nelson Pinto and my colleague Andy Temmerman. And on behalf of my good co-workers, Simone Cortellini and Anna Castro, who you have seen on several slides, Andy Temmerman, and my good friend Nelson Pinto, I would like to thank you for your attention. Thank you very much. Thank you.
Marc, thank you very much.
Pleasure.
I was paying attention very much, so I'm looking forward to our discussion. And now I would like to welcome Jung Zabalegui here on stage. Give him a big hand. Jon has been trained in the US, in California, at the USC. He is a very experienced periodontist and implantologist since, I said before, he's 30, and you said he's 32. It looks like
30.
Just 2 years, but you're 32 years which you have experience in this field. And I think you come up also with a technique which kind of is trying to go different approaches, trying to see how we solve today's problem with missing bones in a different way. Also now with autogenous tissues, and we're very much looking forward to your presentation, Jon.
Thank you, Ron. Thank you, EAO. Thank you, Jill Cofferado, for having me here. And I'm sure that this is not the slide. Can you go to the beginning of the presentation, please? Further back. Okay, there we go. Thank you. Well, dear colleagues, I've been asked to present the soft tissue solution, which for most of you is going to be kind of strange if we are talking on patients dealing with loss of bone on the buccal aspect. So I'm going to be presenting concept and development of compensating alveolar socket seal. By the way, it has not been published yet, although I've been doing it over 12 years or 15. And I do have some data that I will be presenting at the end. It's not all the data that you would like to have, Ron, but some data of survival rates. And this is the kind of situation that I will like to address. But let's go ahead with the introduction. There has been a lot of work done in the last 20 years to describe what happens around the alveolar process when we lose a tooth. In this review done by Viviane, Mauricio, and Danny Boozer, at the end, in their conclusion, they say, further clinical steps should be considered to compensate for the changes that occur around the alveolus when we have an extracted tooth. At the beginning, we have done a lot of efforts to build up the buccal bone with either guided bone regeneration, autogenous bone, or biomaterials in order to rebuild the buccal bone. Some other techniques, like the one proposed by Professor Sicilia, goes further, proposing the rebuild of the alveolar buccal plate and the soft tissue. But as early in 1996, Nemkovsky already described a technique to preserve the alveolus, creating our bilaminar bed on the buccal aspect and introducing a connective tissue. From then on, a lot of proposals from Stimmelmeyer and Allen, from Rangcharusen, from Koby-Landsberg, who described first the socket seal procedure, which works really well when we have a very large alveolar process, very wide alveolar process. And some others, like Tal, have combined different approaches with connective tissue, or the group by Cousin, who have tried to compare how to reconstruct the volume on the buccal aspect either with bone regeneration or with connective tissue. We must not forget that nature works, and it has been very well described what happens in the alveolus when we do not place anything inside. Not only that, if we do place biomaterials in the alveolus, the mineralization of the bone will be reduced, as described by Araujo in 2015. So the proposal is, why don't we let nature work, create a bilaminar bed, seal the socket with connective tissue that can survive and will survive if you do it properly, and allow for the healing of the alveolar socket on a natural way, promoting the presence of the coagulum, which will be substituted by granulation tissue and invaded by the bone cells from the surrounding and the periosteum. Creating this bilaminar bed is not easy, since the mean width of the buccal mucosa at that area of the mouth and the premaxilla is 0.6 millimeters. So you better be prepared, if you want to do it, to be able to split 0.6 or less millimeters. Now, I'm not trying to get the reconstruction of the buccal bone, and this is going to be, for sure, a controversial aspect of the technique. What I do want to preserve the total volume in order to, in one shot, be able to provide the patient with the required treatment, which is the extraction, the placement of the implant. If we do get primary stability and the head of the implant in an adequate position, in 3D position for the restoration, but we do want to have, from the beginning, the volume needed for the adequate restoration. The toughest part of the compensating alveolar socket seal, for sure, is being able to create this bilaminar bed with this 0.6 millimeter buccal mucosa. The connective tissue is left exposed to seal the socket, and sometimes we have used LPRF in order to help the promotion of the healing of the bone. Now let's see some of these clinical cases. We started out with a simple case. We placed the implant adequately, sealed the socket, and 3 months later, remember that we have not placed any biomaterial inside, we do get the adequate volume in order to proceed with the restoration. This is the final restoration. This is the 5-year CBCT where we can observe where the bone was, where the bone is 5 years later. And this is what the patient looks like with no migration on the buccal aspect, which has been described as the highest failure with immediate implant dentistry, and an adequate position of the papillas on both sides. But of course, this was an easy case because there was no bone plate loss. Now here we have a patient with some distortion of the buccal plate in the coronal aspect. We performed the same procedure. Take a look at the extreme thinness of the buccal mucosa. Nevertheless, we were able to create a bilaminar bed with microsurgical instruments. The connective tissue is left exposed during healing. 1 week later, it should be revascularized if we have preserved the periosteum. And this is the final restoration by my partner, Jaime Gil. And this is the CBCT, again, 5 years later, where you can observe how the bone is preserved. But here, once again, it was an easy case. There was not really a big destruction of the buccal plate. So let's get to a further case where there is some amount of buccal loss. This patient happens to be a dentist and happens to be her own restorative dentist. We performed a non-traumatic extraction. We placed some autogenous chips coming from the burr and sealed the socket. Not totally, as you can see. Not even needed sometimes. This is 3 months later. We reform the profile for the restoration, and the dentist restores herself with this tooth. This is the CBCT. This is artifact. Here you can tell, and there is a total close of the buccal aspect. But this, once again, is only a fenestration, which is not the issue we're talking today about. So what happens when we have to deal with class 2 or class 3 sockets according to the Benny and Hammerle classification? This patient has a cuspid where the margin of the gingiva is symmetric to the contralateral cuspid. She does have a buccal fenestration with dehiscence. We perform the extraction, placement of the implant. You can tell how much of the buccal bone was destroyed after the extraction. Very large connective tissue to seal all the socket and provide enough surface for the exposed area to be revascularized during healing. Cover the implant, suture it over. 1 week later, this is what it would look like with some superficial sloughing of the tissue, but not on the deep areas of the connective tissue. 3 months later, this is what it would look like. Connection of a healing abutment. And this is the final outcome, the final restoration. And this is what the gingival margin looks at the beginning of, at the ending of the procedure, and 6 years later. With not only we have not observed any migration apical of the gingival margin, but we are observing in most of these cases a coronal migration of the gingival margin. And as you can see, the gingival margin on the treated site is pretty much coronal to the contralateral site. When I was asked by Dr. Alcoforado to present this today, I started recruiting class 2 and class 3 on purpose in order to test how efficient the technique can be. This patient with a large amount of bone destruction on the buccal aspect, a very long alveolar process on a dolichofacial patient, narrow alveolar process as all the dolichofacial patients. We perform the extraction. We do have a very narrow buccal mucosa that we have to split in two. We place the implant. You can observe how much of the destruction of the buccal aspect. We need to really be sharp during the dissection in order to be able to produce that bilaminar layer, seal the socket with the connective tissue. 3 months later, this is what it would look like. No loss of volume. This patient still on provisional restorations since it belongs to one of these patients that have been recruited after I was asked to present this for you. Another patient, last year, started out, failure from a do and redo and redo situation due to a traumatic injury during adolescence. Most of the times, these finish up with fractures that will manifestate when they are adults, destruction of the buccal aspect. You can see and you can tell the presence of some biomaterial that was used during the apicoectomies that were done. This is the kind of knife that we utilize in order to create the bilaminar bed. The technique, of course, does not start on the thinnest part of the mucosa. It starts on both papillas, where the tissue is thicker, in order to establish your plane of dissection. So you go to the base of one papilla to the base of the other papilla, and when you have already established that plane of dissection is when you will walk to the middle site of the thin mucosa. Occasionally, you may perforate. Don't worry. Don't flagellate yourself. You do need to go beyond the mucogingival line in order to have enough relaxation of the bilaminar bed. Otherwise, you will not be able to push the tissue inside. Harvest a good connective tissue, and that means rich in lamina propria and poor in submucosa. Suture it in a way that you do not bite on the periosteal site of the bed. Otherwise, the chances of collapsing will be greater. And let it heal. This is the bilaminar bed that we created. This is the healing, and this is a recent patient that's still under provisional restoration. And you do see asymmetry between the restorations, but that asymmetry is what the patient started out with. But those are really not too tough cases. It can be much worse when in February 2015, 8 o'clock in the morning, this 27-year-old patient crying at the office with her mother was not yet crying, and the reason for crying was that September 2015, she wanted to get married. But her dentist told her that it would not be possible in 6 months or 7 months to create a situation where she would look nice in her wedding pictures. So we decided to do the same procedure. You can tell what it looked like. I asked her, do you have a boyfriend? I said, yes. Okay, so we're doing okay for 6 months. Okay, give me your best smile, and this is what she smiled like. And even with this smile, you can tell the situation is not very favorable. This is the CBCT, previous. You can see there is a large destruction of the buccal aspect. This could be considered a class 3 type of alveolus, but we do have a large amount of palatal alveolar process that will give us the needed primary stabilization in order to proceed with the treatment. We extracted the tooth, placed the implant in the 3D position adequate for the restoration, harvested a large connective tissue, placed some particulate from the autogenous bone, and sealed both the fenestration and the socket with this rich laminar propria connective tissue. 1 week later, this is what the patient looked like. This area is deficient in tissue, so she had a regraft connective tissue surgery, and since she was getting married, a wedding present for the treatment of those recessions for free. So at the second stage surgery, this is what she looked like. This is Marc. This is the CBCT prior. This is the CBT post. And this is the initial situation and the final restoration. And she could get married on September 16, as she wanted, looking this good. So the compensating alveolar socket seal, I've been doing it for the last 10 years, measuring what's going on. 389 consecutive patients with different teeth. In some cases, 48, I have not been able to achieve primary stability, and the implants were not placed. In all the rest of the cases, the implants were placed. I had 4 early failures, 1 delayed after 6 months on provisional restoration. And in 11 of these cases, I had to regraft, just as you saw on the wedding lady. I did include infected sites, all types of biotypes. Never I used biomaterials, sometimes autogenous, LPRF, and always CT. I had to regraft 11 immediates, and I had a late complication with an abscess and fistula 6 months after loading due to a cement-retained prosthesis. So, in the last 8 months, since I was asked to present here, I've done 49 of those type of 2 and 3 sockets, and so far, I have had no complications yet. So, things should be as simple as possible, but not simpler. And when I said simple, not easy. It's not easy. Now, the advantages are that it will maintain the buccal volume. You will have control on the height of the buccal, buccal margin. You will not need foreign material. It will promote socket healing, natural, reduced cost and chair time. But the disadvantages are that you will need a second site. You will need specific instruments, a learning curve, of course, and these cases all belong to the complex advanced category described by Busser and Chen in 2017. So with this, I am in 0 remaining time. So I think I've done pretty good with the time, and I thank you very much for your kind attention.
Thank you very much, Jon. I just invite you to sit down, and thank you very much for this presentation.
Can I get some water?
Please stay in here, ladies and gentlemen. It's going to be even more fun now.
Sit down together with them.
Yes.
I go to this corner.
Muchas gracias, João.
You take the middle. Just take the middle.
Yes.
Take the middle.
So, Marc. So now please. I would be so excited to listen to the discussion now. Now I have actually, after this session, I have 2 hearts in my chest. One heart is kind of really excited about the fact that we kind of really are revisiting kind of concepts which we have been taught for decades. I think it is very exciting. Today's implantology, I think we have been facing a lot of changes, and I think we will future on. This is the happy part. The other part is we have to face the fact that the techniques which we have listened today, the 3 of them, they do not yet meet the standard of scientific evidence in order to recommend this to the community, the dental community. Knowing that since 2015, there are more general practitioners placing implants than specialists. And we had 2 lectures which are highly skilled surgeons and one coming from a clinic which multiple people have used this. So these are kind of the 2 hearts in my chest. When I put myself into the perspective of a patient, being now provocative, when I'm listening to the first lecture by José, I get a headache thinking of having a chisel getting bone from my tuberositas. When I was listening to Marc, just seeing the needle getting into my arm starts to hurt. And listening to Jon, I think I cannot eat anymore because of my graft, which I have harvested from the palate. Now today we have techniques available which have been very well proven, which we don't need these autogenous tissues. Is it now a step back? Or is it a step forward? Why do we aim to go in other directions? And maybe start with José. What was your intention to do something which might be also used with artificial materials, with biomaterials? You were once saying in your lecture, that doesn't work with biomaterials. But I don't know whether you know that, whether this has been ever tested. Why are you convinced that this needs to be done with autogenous material? And why do you think, or do you have any evidence why biomaterials might not work?
I don't. Here we have 3 different ways to go from Lisbon to Rome. In my personal opinion, I have more than 10 years applying this technique. I believe in bone biology. I believe that if you were able to take the bone from the tuberosity, you will find the 3 most important properties to bone repair process: osteogenesis, osteoinduction, and osteoconduction. And I don't have any difficulty to convince my patient to take the bone from the tuberosity. I never find any patient that have said to me, no, I won't take any bone from the tuberosity because I will suffer a lot. The morbidity that comes from this kind of procedure, it's really very, very low. Lower than when we harvest, for example, any kind of soft tissue from the palate. I have lots of experience. I am a periodontist. And I've been using and harvest soft tissue from the palate hundreds of times. But answer your question, I believe that if we use hard or hard plus soft tissue as a triple graft from the tuberosity, you will have a very predictable predictable outcomes when we apply and we follow the protocol. This is, I always instruct from the stage that you cannot apply this technique before you do some hands-on course. No, it's not. I think it works for the three kinds of methodology. This is what I really believe.
Thank you. So this is, I think it's important to know that it's really you believe. This believing fits actually to the Catholic University in Leuven. I hope in the future, Jose, we don't need to believe anymore, that we can trust and see data. This is really what I would love to see and would love to encourage you, because that's actually easy to do. But I think we should not believe anymore. We need to have really
this
kind
is
of
what
concept.
I saw before, some data for you.
Good. So
Yeah.
we look forward. We look forward.
Yeah.
Now, Marc.
However, Ronnie, in the review we made, half of the studies use DBBM instead of autogenous bone. And some of the studies use allogeneic dermis graft to cover the bone. So it can be done with artificial.
That's a good point. That's a good point. Now, Marc, I think what we have learned is, on the one hand, that the extraction socket is pretty well covered now regarding the LPRF. The area, but this is not a topic which, it's also a topic which can be done with other materials in a very predictable way. But the interesting part, I think, was really the completely edentulous cases, where you have presented something which really would reduce the invasiveness significantly compared to the techniques which are today considered to be the standard. So where do you see there the future, and why do you think it might once replace then larger autogenous grafts wherever they have been harvested from? Because I think this is really then going into the right direction. For an extraction socket, I don't think that's needed. I don't need to get blood from here in order to treat an extraction socket. I do have very predictable procedures for doing this. But I'm interested in the completely edentulous case with the severe resorption.
Okay, first of all, extraction socket. Often I ask my patients, what would you like to have? Pieces of bone from a cow covered with collagen from a pork, or your own blood? And you might be amazed what they would answer. Secondly, I don't know, but, and I know that you like the word I believe, you don't like this expression, but is a augmented area where a non-resorbable bone substitute or a slowly resorbing bone substitute is involved, is this more susceptible to peri-implantitis or not? I don't know. That is for the extraction socket.
And the rules are here. I'm going to ask the questions.
Yeah, but you are not going to force me what I have to answer. I mean, for that, you are still a little bit too young. Okay. For the full reconstructions, for me, I was simply not able to obtain these results previously with the techniques that were available at that moment. And again, the simplicity of the job is what makes me happy with this technique. Also, you make the surgery clearly less expensive, and the healing is more predictable. So I hope in the future that this technique will be more often used, also because you don't need a second donor site, which is a hell of a difference for the patient. What do we have to lose? Nothing. What can we gain? A lot. And normally, I follow that path.
I think that's a very exciting indication. The last question from my side now to Jan. You're going to go it from a different perspective. You say, okay, I actually don't need really bone. And I fully agree with you that we have been following since decades the recommendation that we have to have at least 2 millimeter buccal bone. But this has actually never really been questioned whether this is necessary. Believing or knowing that there will be millions of implants out there which have no buccal bone and still are, at the end, have healthy peri-implant tissues. Why have you chosen this approach by saying, okay, I give up the concept of being crazy to get as much bone as possible at the buccal, but more focusing on the aspect of the soft tissue?
Mainly because I started doing this very long ago. Not 32 years, but very long ago. At the same time as I was introduced into the use of biomaterials and Lucerne osteology, do you remember when that was?
2004.
2004. By that time, I was already doing some of these procedures on class 1 sockets. So when I received that information with the use of biomaterials, I already had an experience with this type of procedure. So from the beginning, I didn't find the need of using biomaterials in order to have that amount of bone. And the 2 millimeter number is pure empirism. We do not know how much it is. So since I had already had a lot of success and stability of the buccal mucosa without it, that's the reason why, as I got more and more proficient with the technique, I dared to start out with class 2 and maybe class 3 procedures. Prior to that, I used the classical guided bone regeneration with membranes, with reinforced membranes, and any other procedure in these type of class 2, class 3 alveolus. Since I've been watching what happens with these alveolus throughout time when I'm using it, I really don't think the need for biomaterials, taking into account that I use a lot of biomaterials. I'm not against biomaterials. I use them the same way as Marc has presented, with a lot of block LPRF grafts for horizontal augmentation. I do use it, but I don't find it necessary that you need it in the alveolus. Plus, remember, if you put biomaterials into the alveolus, you're reducing the potential of bone healing of the nature, and that has been demonstrated.
Yes. We're going to go further. I think we have a lot of questions here. And
Yes.
Alberto, you might...
We have several questions
voice of
from
the
the audience.
audience.
More of them are technical aspects. I have two. I can condensate the questions to José Carlos Rosa in two. Number one is, when patient does not present good quality bone in tuberosity, what do you do?
Very good question. This question always comes. I'm always waiting for this question. This question is amazing because for those people that intend to apply this technique in your patient's mouth, that's what I recommend you. There are many ways to find bone that, that in places that you see, it seems that the bone is not there. You have to use the right CBCT scan, because sometimes you may have bone from the lateral portion of the tuberosity, sometimes behind the second molar, behind the wisdom tooth, and sometimes the bone is not in these two sides. It's in the palatal side. So we have to know how to figure out where the bone is and how to take the bone, and to use the right instruments in order to take the bone from this donor area. If you ask me, did you find some case that you didn't find any bone? No. In all patients, I found bone in order to restore the defect.
What if you have to restore 4 teeth and you have 2 tuberosities?
Sorry?
What if you have to restore 4 teeth? 4 teeth?
I didn't have the opportunity to show, but I have many cases that I did the teeth extraction, all the teeth extraction in periodontally patient. I insert implants one by one, and I restore all the defects using autogenous bone from the both tuberosities. That's unbelievable, but
yeah,
it's true.
Okay. And the second set of questions are related with the complications. That the question is, have you experienced graft sequestration?
Yes, in the beginning of the development process of this technique, as any other techniques described in the literature, we always have complications, of course. And we have bone sequestration, we have loss of implant, we have contamination of the affected area, we have many difficulties in the way before we developed the protocol. After we developed a strict protocol, very strict protocol, if you follow the protocol since the beginning to the end, it's very difficult to face with any kind of trouble in the middle of this process. Not only talk about the talk about the technically speaking, but also also in the results. Results means which kind of gingival architecture I'm gonna see after 4 months, 6 months, 1 year, 10 years. If you don't apply the right methodology, in the near future, you have problems. This is why we've been following these clinical cases for the last 12 years. And I have many, many clinical cases that we have more than 12 years of follow-up.
You make, first you place the implant, then you make the provisional prosthesis.
Yes, this is
and
the
then you
real
make the graft. This is the key, right?
Yeah, yeah. That's the key. Tooth extraction, apply minimally invasive procedures, implant installation, always the correct three-dimensional position, make the provisional restoration with ideal emergence profile, and the last, but not least important step is the bone reconstruction.
Okay, thank you. Some questions for Marc. Many of our colleagues are wondering about what type of biomaterial you use with LPRF.
Yeah, very good question. Since we wanted to collect the data to publish it afterwards, we decided to work with one bone substitute, thinking about the vertical and horizontal bone augmentation. And so far, we have been only working with BioOS because we thought that this was the golden standard product for horizontal bone augmentation. But it's clear that we have to find out whether different bone substitutes could even help to have a better healing. But I cannot answer that question.
And some want to know what is the healing time before implant placement?
We have taken this very safely. So the horizontal augmentations, they were left for healing 6 to 8 months.
6 to 8 months?
Yeah. If you ask me, do you think you could go in earlier? Then my answer is, I could think, but I cannot prove.
Yeah. And what do you think is the resorption time for the LPRF membrane?
Also a good question. What you have seen from the extraction sites is that the LPRF basically is not resorbing. It stays like a kind of a scaffold where slowly blood vessels are growing in, and then it is replaced by. If that replacement is the question, definitely not within the first 3 to 4 weeks.
But you don't use it as a membrane because you place a membrane over the graft.
You are talking now about horizontal augmentation?
Yes.
Yes, there we, so far, and again, this is a good suggestion. So far, we have only been working, except 1 or 2 cases, always with the collagen membrane. Question is, do we need this collagen membrane? And also that question I cannot answer, but it could be possible to work without.
So we have
but
to
we still have to prove this. So
we have to invite you next year.
Next year would be too early, the year after.
Okay, year after. Some questions for John. What kind of provisionals do you use during the soft tissue maturation?
I'm not a restorative dentist, so that depends on the restorative dentist approach. Pretty much at the office we use Maryland bridges in order not to load it, because although I do achieve primary stability, I cannot, depending on the type of implant, if it's conical or not, then the immediate restoration is or not recommended. So if you don't want to run any risks, Maryland bridges do a great work for you. Plus, they will guide the healing of the emergence profile.
Okay, and the last question, where do you take the connective tissue graft from? Tuberosity or palate?
Not everybody has the same amount of connective tissue. Not everybody has the same morphology of the palate. You will find vertical pallets, you will find horizontal pallets. Most of the times I take it from the palatal site of the homogeneous area of the mouth. So I'm treating a tooth on the right side, I will treat the palate on the right side. And I will try to harvest it between the first molar and the distal of the cuspid of that homolateral site.
Okay, finished.
Very few times I go to harvest it from the tuberosity. I'm not sure it's going to be the best donor tissue for that. I'm not sure. And I'm not sure it's going to be long enough. So I prefer the area between the molar and the cuspid. But when I start doing the trimodal, I will go to the tuberosity.
Thank you so much.
Good. So I think that's a good end. We run over the time. Thank you very much, the whole of us.
Thank you.
I think
Welcome here at the EAO channel live. Stay tuned because as the in the auditorium, we are here downstairs in the middle of the lunch break, and both José, Marc, and Ion are on their way downstairs here for some exclusive Q&A for you as an online viewer, and also an invitation to all the people here on site. If you have questions for our speakers, they can join in as well. I have been watching this session together with Ferruccio Torsello. Ferruccio, we've been upstairs. For our viewers that tuned in later, let's summarize. What are the, we've learned about 3 very different techniques to do implants in a case of buccal bone loss. What are your personal takeaways from each speaker?
Well, first speaker, he dealt with this immediate dental veil reconstruction, harvesting tissues, could be bone or a triple graft from the tuberosity. It was very nice lecture, outstanding cases, and he uses these tissues in order to reconstruct, rebuild, protect the immediately placed implant.
Yeah.
Immediately placed with immediate restoration. So was very nice technique. What I got from this, my feeling from this lecture was that this technique is not easy, and the speaker also admitted this. But worked very well in his hands, and above the main advantage is the fact that there is no biomaterial used.
Yeah.
So everything is, would say, autogenous, natural, would say. Okay, and so this is a very good issue.
I realized when we were watching that it seems that the harvesting of the graft had the triple layer graft with both bone marrow and bone and vascularized tissue.
Yes.
That is a critical success factor, I think.
Yes, absolutely. This absolutely critical, and also not easy. So we, as soon as the lecture will come, we will ask about this, because it takes a learning curve. You have to dedicate to this.
Next up, we saw Marc Quirynen.
Marc Quirynen did great. He showed us how to treat extraction sockets. So he grafts with this autogenous material, which is LPRF. Once again, we have something in common with the previous lecture. Everything is autogenous. So no xenograft, no other materials, no materials coming out from the patient's body have been used.
Yeah.
He takes another kind of approach. He waits a lot of some time. He waits longer. He waits for tissue healing, and then he performs a surgery which is easier. So a totally different approach, slowing the time, the treatment time, but going for an easy procedure. So this is.
And he showed 2 situations, one with a single tooth, and then with an edentulous patient with a lot of bone loss. Yes. And when you were sitting next to me there, you actually said, "Ooh, this is something I'd like to try in my clinic." What struck you there?
he dedicated 1/3 of his lecture to this, to not only to extraction sockets, but to bone atrophies, so edentulous ridges, extended ridges with a lot of atrophy. And he showed how he can create some blocks out of these LPRF membranes. So he got some LPRF blocks, and he grafted the edentulous ridges with these blocks and covers with collagen membrane. And well, the morbidity of this procedure is very low because it just takes some blood, while currently the normal the gold standard is to take autogenous bone blocks either from calvario, iliac crest, or from intraorally from ramus or chin. And so having just a
broad blocks,
yes,
basically.
come on, it is very promising. The case he showed was really nice. He did greatly, and well, it is very promising because it changes the game here.
Yeah. So what struck you and what took it straight into the clinic is the fact that it's so far less invasive.
But absolutely, it is less invasive, by far less invasive, not just a little bit.
Yeah, interesting. Well, I'll be looking forward to chat with you in the future to learn what you've discovered there.
Yeah. I will go deeper into this, I think.
Perfect. Then third up was Zabalegui. He perhaps potentially kind of rocked the foundation of implant dentistry, because when we started our pre-show here, we learned about the textbook says you need 2 millimeters of buccal bone. Jon says, no, I don't.
Yes. Well, he does this immediate implant placement plus this beautiful connective tissue graft. Once again, no biomaterials are used. So there is something in common among these
everything is very natural and autogenous.
No, I mean, biomaterials are used, but they come from the same patient. It's different stuff. And well, the connective tissue graft showed in his hand fantastic results, very nice, and he had very good success. He mainly showed cases with one single tooth missing, but in the aesthetic area, which is the area where we are most concerned of. So it was a nice lecture. When it looks like that from his lecture that bone reconstruction around implant is not needed, which is exactly the contrary that on what we have been talking about in the last 10 or 20 years, the contrary of what it is written in textbooks. And well, it is questionable. There is a little bit, there could be a lot.
For you personally, there wasn't an immediate, ooh, I'm going to try this.
My opinion is that sometimes our traditional graft do not work, and we can end up with implants which are not fully covered by bone, but still, if the tissue are thick, they still work. So I think that bone is not mandatory in all cases, especially when the thick periodontal biotype could compensate a little bit. But this is acceptable for sure when it is a treatment that is not performing as we desired. But to recommend to do this in all cases, this is a little bit...
it's too early.
Too early. This is too early.
It's an interesting approach to learn about.
Yes.
It's an empirical, clinical case.
Cases, yes.
Significant amount of cases.
I would say that we also have to think about who are those people who are promoting this new approaches or these different approaches. And well, Jon is not an average dentist, he's not an average periodontist. He's a very expert, very talented, very skilled periodontist, working for more than 30 years with a practice devoted to this, with sound basis. his hands are not average hands.
Exactly. And
And
that is kind of the warning also that
I
I
will-
heard you made around José's work. This
Yeah.
is high skill
Yes.
level of
The
procedure.
same. So I would say the approaches are different because those are two guys which are very experienced and they show something that works very well in their hands. But then we have to, as a EO, we have to recommend treatment guidelines. And those procedures are a little bit too advanced to be considered at the moment.
Yeah, for general
For general-
clinicians
for
and
general
or
clinicians.
even for general implant dentists,
Yes,
right?
I would say I will not recommend for GPs or will not recommend for beginners. The LPRF approach is different. It's more conservative approach. It helps you to have simple surgery to treat cases without augmentation because you have already augmented at the moment of extraction.
Yeah.
So it is a totally different approach. It comes from a university where a lot of people are working, different sensibilities, different hands, different knowledge, and well, it is more devoted to be widely used by any clinician. But on the contrary, it is as a backdraw, we have the problem that it elongates
It takes a lot of time.
a lot of time because 4 months, 6 months.
He even mentioned 8
Yes,
years now on
probably
stage.
in the most challenging cases. That could be, how can I say, not really acceptable for some groups of patients. So we have to find how can I say, a balance between all this.
Yeah. So
options.
basically, if we help our viewers to kind of distinguish like about what technique fits in what case,
Yeah.
it's perhaps not case driven, but
Yes.
more clinician driven, right?
Well, I honestly think that one of the major factors in overall implant surgery success is the skill of the operator. So this is not a matter of biomaterial, this is also a matter of the skill of the operator. So the operators should be self-aware of their skills and decided on the basis of their skills. This is very important.
Perfect. So, if you're still with us live here at the EO channel, we're very glad you're watching us. And now is the bit that is most exciting about this live broadcast. And that's the fact that you get exclusive access to our 3 speakers that we've just been following. Dus, gentlemen, please join us here in the studio. Ferruccio, switch over to one my side.
Congratulations.
We are
Very
live,
nice.
so if you have the ability to
Ivan,
chat,
you did great.
please let us know where you're watching from and send in your
Very good.
questions.
Very good.
Jan, welcome. Yes, please come to this side, Ferruccio over here. Gentlemen, good to have you. That was a very interesting, very high-class session. If you're joining us later, make sure you rewind and look that session back up. We have been following along, not only me, but luckily I had my co-host expert on my side, and we've prepared some first questions. So I say, Ferruccio,
Yes.
shoot.
So let's go for questions.
I cannot hear you.
Cannot hear me. How can we do if you
Just
doesn't
speak loud
Just
and
speak loud,
comes
yeah?
over the speaker.
So come close. First question is for you, as you were the first one.
Yep.
You showed a beautiful technique, beautiful cases, which really gave me a lot of questions. But first one is, what about complications? What type of complications could we expect, and which would be the frequency?
Well, we have already discussed about this from the stage.
A little bit, yes.
We had some complications when we were in the beginning of the developing process of this technique. And we have all the complications that you can imagine. As bone sequestration, loss of implants, loss of papilla, and we didn't have good results, of course. As soon as we develop the protocol, a very strict protocol, it's really, really difficult to find any kind of complications when you follow the protocol. The protocol is performing 15 steps, and we cannot jump any steps. If you jump, you will fail. If you follow the rules, you will succeed. That's what we've been following in the last 12 years. Nowadays we have thousands of dentists around the world applying this technique and getting the same result. So I'm very happy about that, because when some colleagues send some images for me and I realize, wow, more beautiful than mine, that's amazing for me. And so with this technique, the most beneficial part is not for the dentist, it's for the patient. And the dentists are what I'm looking for, to reach them in order to apply this technique in their patient's mouth, because I cannot apply this technique all around the world. So my job today is to spread, to teach as much people as I can, in order to prepare them to apply this technique in a very safe way and with very predictable results.
Okay, thank you.
And you say you've reached that phase now. It is very reproducible. You said in your final remarks, we were looking and said, well, this looks like a high quality procedure. I see Marc nodding about that.
You should have some experience to put implants in intact socket before you apply in compromised socket. Of course, you have to have experience in how to stabilize an implant, because this implant stabilization is one of the keys in order to succeed with this technique. And you have to know how to take either bone or soft tissue from the tuberose. That's all you need.
Yeah.
It seems to be difficult. It's a very sensitive technique, but it's not difficult.
And how often do you have the chance to harvest from the tuberosity? Is there any case that you cannot do like this?
I never found any case that I couldn't find any tuberosity from the patient. I always find some piece of bone that I need. Of course, in some cases it's more difficult. It needs more experience, but depends on your learning curve. As soon as your learning curve grows up like this, you would be able to take bone in cases that seems that you don't have any bone right there.
Because Jose, we were watching and we were concluding that it seems that the harvesting of the graft is a very critical success factor in this case.
This is the easiest part of the technique.
Is it?
This
And that already looked quite complicated to us.
The fastest part of the technique.
Okay.
This is why we always leave this part for the end of the procedure. I extract the tooth, insert the implant to make the provisional restoration with a very critical and ideal emergence profile. And after that, I go to the tuberose and take the bone, and immediately after I take the bone, I start reshaping the bone according to the defect configuration. As soon as I do this, I insert and I never remove it. I insert the graft and I never remove the graft anymore.
Okay.
You are my patient.
Yeah. So you say it's not, yeah.
You just stabilize it by mechanically.
Mechanically, just a position. In the remaining bone. The remaining bone I use to stabilize the bone. This is why the critical part is to reshape the graft according to the graft, the bone defect configuration. That's my job, to teach them, the audience, how to know exactly the dimensions of the defect, because you have to know prior to take the bone from the tuberosity. As soon as you notice the exactly dimension, the shape, you are able to take the bone with the dimensions very similar to the defect dimension.
Interesting. Thank you. In the meantime, I think they've tried to fix some of the audio, so for our camera people, if we can scoot out a little bit again. Yes,
Okay.
let's try and see if we can hear each other. And I see that many of you are still watching, so please use the opportunity to use the live chat feature and send in your questions straight here into the studio, and I will relay them on your behalf. In the meantime, I trust my co-host Ferruccio, who's been scribing a lot during your talk. So Ferruccio, take it away.
I have a question for Marc. First of all, I congratulate with your lecture, which was really nice. It really was really impressive for me, especially the part for more complex cases. So, first question I ask you is to give us a short recap about the timing for implant placement after the graft with the LPRF. In single tooth cases and in wide edentulous spaces.
Okay, for single tooth situations, If you take a cone beam after 3 or 4 months, you see already a pretty nice bone healing, but the density is not really exactly the same as on the neighboring sites. But we have done a number of surgeries after 3 or 4 months with observing a very nice, well-vascularized bone. So I would say for single sites, 3 or 4 months healing is sufficient. If you go for the more extensive ones where we have used a bone substitute, there we have always been waiting 6 to 8 months.
6 to 8 months.
The question is, can you go in earlier? I think that's our job to check and to do a study where we do it after 4 months. But so far, I cannot suggest you to go in faster than after 6 months of healing.
Okay, so I would say that for big cases,
Where we use a bone substitute,
yes, for big cases, the treatment time is almost the same if we use blocks, extensive block grafts. We can think it is comparable.
treatment time is the same, yes.
Yeah, but if we go to small cases like single tooth extraction, I would say most of the dentists in Europe, they go for an early placement, 6 week, 8 week after implant, after extraction. So which would be the benefit to wait a little bit more like you suggest, so
Okay.
to wait 3 or 4 months?
Okay, in our situation, we are not using a bone substitute. We are just using the blood of the patient. And we will have, after the healing, we have a very nice, well-vascularized bone without remaining bone substitute. And that's first one advantage. The second advantage is it's 100% autogenous. If you ask your patient, what do you like to have in your socket? Bone of a cow and collagen of a pork, or your own blood? I mean, you can understand what they will answer.
Yes.
So these are the major advantages.
Yes.
So Marc, if I may, we concluded that actually all three of you are focusing on autogeneous materials to generate new bones. So I'm wondering if you listen to each other. Is there anywhere, because Ferruggio said at some point, ooh, this is something that I would like to try. When you listen to each other's techniques, Jose, is there anything where you think, ooh, maybe I might use some of the LPRF in some of my cases, or Ion? What happens when you listen to each other?
Occasionally, when I see a large destruction, I do place LPRF
Okay.
underneath the compensating connective tissue.
Exactly. So you say, yes, very great work, but only in the larger defect.
And I haven't not used yet the trimodal approach that José Carlos has suggested, but I think it's a great, great technique.
And for you, Jose, I mean, we talked about
Yes,
it a little bit yesterday. You're about speed, right? Doing everything at once?
I think either connective tissue or LPRF, in my point of view, we have different indications. But for that specific indication, I think to use a graft with a high potential mechanism of bone remodelation, that's the key in order to stabilize the tissue along the months and along the years. But of course, before I applied this technique, I had been using, for example, biomaterial in order to do the same. But I wasn't unhappy about the results because I always fail means I always feel that in a certain months or a year or 2 years after I did the surgery, I felt that a slightly gingival session, loss of the papilla in height. I wasn't happy. The patient wasn't happy. This is why I tried to move in a different direction.
Interesting. Yeah, thanks.
Okay, and now I have a question for Jon. I also congratulate with you because your lecture and your cases were outstanding as well. And well, I would like to, I've seen a CBCT of a case where you place an implant where bone can be seen not for the entire length of the implant, but I would say 2/3 or 70%. So usually we, all experienced clinicians, they know that when you have an implant with an augmentation, you can have a complete success or an incomplete success. And sometimes when the success is not complete, you have a small portion of implant which is not surrounded by bone, and it works perfectly. This comes from our experience. Your approach seems to tell us to do it on purpose.
Not really.
And
I would love to have as much bone as he has, but we still do not have the fact that we need that bone, because what you have seen in the CBCT is that in the coronal third of the strict buccal aspect of the implant does not have 2 millimeters of bone, but it does have some amount of bone. How much? I don't know, from the CBCT only. The rest of the implant on the mesial, distal, and parallel aspects, it has a large amount of bone. Plus, the large amount of connective tissue, supracrestal, which provides stability for the peri-implant tissues and prevents the possible loss of marginal bone around the head of the implant. I think there are many trends in the literature working in that way to provide a large amount of healthy connective supracrestal tissue in order to avoid marginal bone loss. And that, I think, is what this technique provides. A large, not only in the vertical direction, but specifically in the horizontal direction, what has been called the horizontal biological width, which we did not look in the past. We only focused around teeth on the vertical amount of biological width or supracrestal attachment, and we've never looked at the horizontal. In the year 2000, Uli Grunder suggested that we needed some amount of horizontal biological width or supracrestal mucosa, peri-implant mucosa, and I think this becomes a critical issue.
okay, thank you. Thank you for
Gentlemen, this is where the exciting part starts. If you're just joining us, we are live on the EAO channel, and people start to make use of why we are live, because they're starting to send in questions. So let me read out the first two that came in. The first one is from Ibrahim Murtado, who's joining us from Syria. We're glad to have you with us. And this question, he says, greetings from Syria. I think this question is for you, Marc. Do you think that using blood concentrates can be an alternative for autogenous bone grafts? Because I don't think, he doesn't think, they act the same way or lead to the same results. So he's kind of challenging the whole principle of using blood concentrates. Can we expect the same results? That is the question.
You are talking about extraction sockets, I guess, single sites.
It doesn't specify,
No.
but in general,
Yep.
the blood concentrate versus autogenous bone graft.
Okay. To answer that question in a scientific way, you have to run a study,
Yeah.
and we are running that study at this moment.
Okay.
So, but even if it would not reach the real same quality, the fact that you do not need a second donor site is a huge benefit for the patient, and that would be, for me, more important than to have perhaps 0.5 millimeter more buccal bone that we probably even don't need.
Yeah. So you say I'm not even that interested in that answer as long as I have a functional good outcome and that I simplified my procedures.
Explicitly the last part, to simplify the procedure for myself, but also for the patient.
Exactly. Clear? I hope that answers your question, Ibrahim, and if not, please continue chatting with us. Second question is for you, Dr. Rosa. It's from the Instituto Carranza. I don't know if that's your own institute or they're familiar. But the question is, did you ever see hyperplastic soft tissue response on the long term with tuberosity grafts? And it's from Dr. Nelson Carranza in Argentina. So Argentina, this is a very early good morning, I think, 6-hour time difference. And thank you for the wonderful lecture, he says to all of you. So,
Very good question. Thank you for the question. The answer is something like this. According to the literature, we know that when we harvest connective tissue from the tuberosity, a very thick soft tissue, this soft tissue is very tricky to be worked with. Because if you work with a thick soft tissue, we will expect it's still growing. This is why the literature recommends to harvest connective tissue at the most 2 millimeters width. If you work with this kind of thickness, you never find any growth. It seems that it still grow on it's forever. But that's the trick, to work between 1 and 2 millimeters in thickness. If you work, you won't expect any change in the soft tissue.
All right, well, great, thank you. And Ibrahim is responding that he was indeed referring to socket preservation. So I think we answered him well. We should be aware that our live viewers are on a slight delay. So thank you very much, Ibrahim, and also Dr. Carranza. Thank you for joining in live. I look around the audience here. If there's any questions, just raise your hand and I'll come out and get the question. Just to round up, our half-hour debrief is almost gone. Ferruccio, any final really pressing comments or questions you'd like to make?
Well, I feel this, when I see at these three outstanding lecturers, I saw two lecturers which propose their approach, which comes from a great clinical experience. So it has some advantage, which is to shorten treatment time for both of you, and you showed fantastic results, no doubt about this. But also, both of you mentioned that it is something that works in hands that have been trained to do so. So it's, I would not honestly recommend your approaches for general practitioners. While
Not on Monday.
Not on Monday, yes. On the other hand, Marc is looking for something which makes dentist life easier, probably. So we pay a little bit in treatment time. Our patients pay a little bit because they wait longer. But what comes out is a procedure which honestly looks easier, I have to be honest with you, and also simplifies the treatment. So different approach from different experiences. And well, I would probably recommend Marc approach to people who are not whose learning curve is not yet mature. This is what my feeling. And what I also think is in common among the three of you, as said before, is the fact that none of you is looking to use biomaterial different than autogenous tissue. So this, for me...
Do we think we might be hitting on a trend here? Is this a coincidence that all three of you are focusing on autogenous materials, or is this a direction that this field is moving? What is your take on that?
You first.
Okay. Remember that in our augmentations we are using.
Yes, in the big ones.
Me too.
So we are still working with these components, and they still have their role. Again, because it's easier to be used than to go and collect bone chips from another area. Although I was really amazed with what you can obtain, and I can fully understand your technique, I mean, without doubt. But if possible, why should we take a foreign material if you can find everything in your oral cavity or in the arm?
Yeah.
So I think there is, for me, indeed, a trend to go more to autogenous components, products. Yeah.
Yeah, I see you're nodding as well, Jon.
If we use, for example, biomaterial, you always need autogenous tissue, soft tissue, or maybe to complement with hard tissue as well. We can do a mixture, something like this. And I think the literature, if you follow the literature, it's increasing a lot the number of the articles very recently talk about hard and soft tissue collected from the intraoral sites, like for example from the tuberosity side. And I think, if I'm not wrong, I think the literature is going in that way.
Exactly. So
There's
we might.
a trend. Yeah.
Yeah, interesting. Well, thank you very much for sharing and being here with us live online. Jon, I think we're looking forward to more cases and more academic evidence of the procedure you've proposed. Thank you for sharing that with us. Marc, before we sign off, we talk a lot about that people should educate themselves. You highlighted it on stage as well, but let's do it to our online audience. EAO is organizing a 2-day workshop together with you. What will people learn there?
Well, all the possible applications of LPRF, by the way, thank you for asking, going from the GBR that we have shown, ridge preservation, also sinus augmentation. Also, it's important in some cases to wrap your implant with LPRF in order to improve, facilitate the osseointegration process. Also the enlargement of keratinized tissue, again to improve the quality of the soft tissues. These are all aspects that we will teach peri-implantitis treatment. So it's a really intense program.
I saw in your slide that there's only room for 30 people, so where do they have to go if they want to sign up?
Okay. We think that for such a workshop, we cannot serve more people. There will be a team of 10 postgrad students to support them. Yeah. But I think teaching and one supervisor for 3 students or dentist is a good ratio.
They better be quick in signing up. And José, you referred to your academy already on stage. You also wrote the book on IDR, so I think there's a lot of educational material available if people want to go deeper. Thank you very much for sharing.
Thank you so much.
Federico, thank you very much for guiding me
to
this very interactive and interesting session. And for you, if you haven't done so, hit the subscribe button right now on the EO channel here on YouTube, so you'll be the first to know when a new live video will start or when a new video is published. Key message here today, keep educating yourself because there's a lot of developments going on in the field, so you're already on the right track watching here the EO channel. And we can only say we look forward to see you in person at one of our future congresses.